It's my pleasure to introduce our two speakers. First, we have Dr. Mark Dermer from Ottawa, Ontario. Mark is a family physician. He's the medical director and chief privacy officer with Dialogue Technologies, an early adopter of virtual care in Canada, and a noted speaker and writer on telemedicine and some of the challenges and opportunities. I'm also very pleased to introduce Dr. John Polovich from Abbotsford, BC. John is the telehealth lead for the Rural Coordinating Centre in BC, working extensively with BC First Nations and over 13 rural communities in making telehealth happen to serve Indigenous communities. He's also at the medical school level coordinating this kind of digital work, and also works in the Rural Education Action Plan in the province of British Columbia. And again, both experienced clinicians in the provision of virtual care. We're here to talk about the challenges, to answer questions, and we'll be looking forward to yours. We have a few slides to show just to get us off on the right foot. First of all, we do have some disclosures of financial support to make that I'll leave on the screen for about 20 seconds just for you to read for both Mark and John and myself. Moving to the next slide. We have learning objectives for today, and I'll just read those loud for you. After the webinar, we hope that you'll be able to identify the characteristics of patient visits that are suitable and not suitable for virtual encounters. We're going to hope that you'll be able to list the elements of patient authentication and consent that's recommended in virtual visits, devise an approach to integrating virtual care into your office flow, including visit preparation, and hopefully be able to encourage your colleagues in the adaptation to virtual care and your expansion of that, and point them towards resources that will make a difference. With that, I want to talk a bit about some of the background technology that you'll need to know to participate today. We are looking for your questions and input. Some of you are on Facebook Live. More of you, I think, are on YouTube streaming this video webinar. In both platforms, you'll be able to ask our guests questions. We have a diverse audience today and a big one, and we know you have lots of questions, but we do want to focus our questions today, at least, on questions from family doctors that do pertain to virtual care itself and our adoption of that in primary care. We are receiving other questions about other aspects of COVID-19, and we will be feeding those into future webinars. If you're on YouTube right now, you can submit your questions in the chat window. You'll need to be logged in, of course, to your Google or YouTube account. If you can't see your chat window, it may be that you're in full screen mode, which you'll need to escape from. And make sure that you select the tab on my screen, the upper right corner, that says all chat, so you can see all the comments coming in the chat window. If you're on Facebook, of course, you need to be logged into your Facebook account if you want to submit questions on that stream. And that stream appears either to the side of the video on your monitor right now or below the video feed, depending on your device. And we have staff monitoring both feeds, and they'll be feeding your questions forward to our speakers. For everybody watching this live right now, you are eligible for a certified MainPro Plus credit. You're going to have to complete a short survey and registration form that will be pushed to you on the chats on either of our platforms towards the end. And we'll ask you to complete that survey before the end of the day, Friday. It's brief. We'll also be asking you for suggestions about topic areas for future clinical webinars that we're going to do on COVID-19. And I'll also mention that an archived version of this video will be available for you to watch or for you to tell your friends and colleagues about, and it'll be available on our CFPC website at cfpc.ca/clinical webinars, and we'll be sharing that shortly. And I'll just announce right now that we are going to be for sure doing a webinar in 2 weeks on April 9th, and our staff is working hard to make these weekly events, but I am able to say that we'll definitely be on your screens in 2 weeks' time, talking more about symptoms and some of the clinical elements of COVID-19. So those are my introductory comments, and again, thanks for tuning in. It's noon on the East Coast. I'm sitting in Winnipeg today, where it's a few minutes past 11. John's on the West Coast, and Mark, I think, is in Ottawa. So this is the world we're all living in now, of course. Again, I want to welcome John and Mark to our webinar, and maybe I'll start with Mark with just a general question to get us going about what exactly is encompassed when we're talking about virtual care, and what are the kinds of modalities whereby family physicians can be interacting with patients.
Thanks, Jeff. I think it's readily acknowledged that virtual care divides into two general categories: asynchronous and synchronous. Asynchronous is any written communication with the patient. Secure messaging, of course, can't be just general email if we're going to stay within the regulations. And the synchronous side, one that we've been using for decades, is telephones, which we use for voice calls. But most people, what I think has driven a lot of the change now is the adoption of video conferencing to use virtual visits face-to-face in real time with the patient.
Thanks. Let's jump right into a question that I've received around consent, and this is an important topic, obviously, and maybe I'll ask John to take the first stab at this. One of our viewers is wondering about what's the approach to consent. Are there standard forms or scripts that can be recommended or obtained that we can be using as we kick off these interviews? And maybe you could talk a little bit about whether we need to, or how we need to make sure that we're talking to the person we think we're talking to. John, any comments on that?
Sure. I'll give you my personal take on consent. I think number one, there are many standard forms that people can access through the CMPA has good ones. Most of our professional bodies in each province or territory, I'm sure has one. We have them here through our Doctors of BC office. So I think consent forms are easily available and can be utilized. I think that verbal consent is certainly a very acceptable approach. Certainly it is in British Columbia, and documenting that. For family physicians who have a longitudinal relationship with their patients, however, I don't think consent needs to be overly discussed. I think as a patient's, not unlike patients coming into your office, there's implied consent, and people connecting, also reaching out for support. There is an element of implied consent. Again, having said that, when you're starting the journey, I've been doing telehealth with my patients for a decade now. Over that time, that the whole issue of consent has drifted into the background, because telehealth is just like a face-to-face visit. It's been normalized into the access for patients and in their lives. So they toggle between an in-person or a virtual world accessing their family physician, and the consent issue has long ago been dealt with. But I think for people that are starting off for the first time, obviously acknowledging the consent is something that should be done. Where I think the thinner ice is around consent is when you're dealing with patients that you have no relationship with. So in other words, there's an anonymous interaction between a healthcare worker and a patient. That's a much more vulnerable interaction, where consent really needs to be stressed and documented. So again, and we're in a public health crisis. This is not something that I would suggest at this current time to dwell on. I think you should acknowledge it and document it and move on. That's my practical advice for people.
Thanks, John. So Mark, a question for you that we received, and it's, I guess, just the obvious one based on your experience, maybe just a rundown of the kinds of problems that are quite suitable for telehealth visits video or remote visits, virtual visits, and the kinds of visits where we need to be cautious and maybe quickly convert to face-to-face. What's your experience or reading around that?
So, let's start with, situation normal rather than public health emergency. In situation normal, our regulatory colleges have been very clear. There can be no compromise granted just because we are on a video visit. In other words, if the encounter with the patient in the course of the history and the exchange would lead us to need to physically examine the patient, then that patient needs to be referred from a video visit to an in-person encounter to be examined. That's the standard most of the time. However, within that standard, there's still plenty you can do. You can do virtually anything in mental health. You can do a whole lot of dermatology, provided that you can get good resolution photographs. I'll point out that streaming video is often inferior. You can do sexual health, contraception, sexually transmitted disease screening and treatment, travel medicine, although that's not something people are thinking a lot about right at the moment. Some chronic disease management, particularly when the parameters that we're using to measure the patient's status can be done by lab work and don't require a physical measurement, or when the patient can have equipment at home, like a good quality home BP machine or a glucometer, as well as infections that don't really rely on physical exams, sinusitis without any other upper respiratory symptoms, urinary tract infections, and also minor skin infections are appropriate as well. However, in a public health emergency where telling a patient to go in for a physical exam puts the patient and others at risk, we are already seeing early indications from our regulators that we need to take the whole picture into account. And I think that skipping a stethoscope exam in certain cases might be acceptable. Not palpating an abdomen might be acceptable, provided we're transparent with our patients about the compromise in the usual standard of care that's occurring because of the decisions we're making.
Thanks, Mark. Go ahead, John.
Yeah, I'll just add, if I could, a little bit to that, because I think it's really important. Over a decade of work in this area has taught me that I don't know a lot about what I don't know. And in the communities that I support, the premise is you start by having a patient access you, and you determine what you can do. And like any new tool and new style of interaction, meaning a virtual visit, as time goes on, one's comfort with the tool, both as a provider and the patient, changes. And so what I've learned is that rather than have a set list of what people think is safe to do and not safe to do, I'm not sure that's necessarily the best approach. In other words, in the moment, you will decide holistically what is the best approach for this patient and make that decision. So over the years, we've cardioverted people, we've treated sore ears, we've treated rashes, we've treated chest pain and sepsis and high blood pressure. And I think it's fundamental to understand that the tool of telehealth is a tool that can be used to help, and it can also do harm. And our job as healthcare providers is to understand how best to utilize this tool in the moment with the patient in front of you. I think another really important concept to bring us back to is the fundamental basic understanding when we all went to medical school on the first week, and we're taught that 80% of the diagnosis, of the answer, is in the story. It's in the story. It's not in the physical exam. It's in the story, and then you observe people. And I've learned over the years that my observational skills and my listening skills are heightened through telehealth. And I'm a much better listener to the story. And if we have 80% of what we need to get is in the story, the other bit is observing people, how they're breathing, what the color looks like, the stress on their face, then you start to see that the amount you're going to gain with a physical exam is less and less and less. I'm not discounting the physical exam isn't important, but there's a lot we can do in a thoughtful, safe way, more than what we think we can do by good teaching, education, and experience doing this. And so what you really want to do, as Mark alluded to, is you have to understand holistic risk. What's the risk of me not doing something versus me sending someone to get something? And in COVID, that amplifies and illuminates the risk very greatly. So sending someone down out of their home is potentially a lethal decision. Okay, so I have to make a clinical decision in the moment with someone who has a symptom and a story, and make the best decision for them in that time. And I think if people think about in that context, rather than an algorithm, then they'll be on much safer ground helping their patients. I hope that makes sense.
Yeah. Great comment. So let's just follow on that theme, just around watching, learning a lot by observing closely, and how much that can tell us, along with the story in particular. I do want to talk about how we establish connections with people virtually. I certainly have family members worried about their ability to connect with a doctor on a screen, particularly people less familiar with video technology. So maybe I'll ask you this, Mark. First of all, what are the ways in which a physician can establish rapport and trust on the screen, particularly, I guess, with someone they don't know well? Clearly, if it's Mrs. Jones and I've known her forever, it's not going to be as big a problem. But what are the ways in which we can use our words and actions on screen to help a patient trust what's happening and to divulge what's happening on their side? What have you learned?
I think that's a great question. I think that John's partly, begun answering it when talking about how we need to be really active listeners and really very engaged with the patient as much as possible. Patients notice when they're being listened to. They notice when you make eye contact. So something as simple as making sure your setup has your camera right above the image of the patient will assure that when you're looking at the patient, they see you looking in their eyes. It sounds almost trivial, but it's true. And I think that the best practices in patient interviewing and listening, and while using the powers of observation that John articulated so well just a moment ago, I think those things not only serve us, but they serve to build the relationship, making sure that you're demonstrating empathy. And in those times when a patient may not want to hear that you can't really complete the assessment you ideally would like to, always underlining the fact that you're acting, in their best interest, because I think that's what we're doing when we do so. And I find that patients, respond really well to that. They're super appreciative of the opportunity to, what's different between John's practice and mine is he does people at great distance, where I'm seeing people in urban centers who may be, half a block away from the nearest, conventional clinic. But people appreciate that, you're making an effort to help them. If you really are making an effort to help them, just demonstrate you do that. Watch closely, make eye contact, stay engaged, and that usually works.
John, anything to add in terms of kind of communication skills, things that you kind of emphasize in virtual visits?
Absolutely. So a few years back, a colleague, Dr. Stefan Grabowski, and myself, and Nathan Toe, who's a medical student at that time, wrote an article in the Canadian Family Physician around the core components of video visits in terms of verbal and nonverbal cues and the importance of them. And I think Mark touched on them. I mean, our job is to, in patients that we don't have an established relationship, is to establish a therapeutic alliance as quickly and as effectively as possible. And so that's very doable over technology. And certainly video technology adds the added component of being able to see a patient as opposed to the telephone where you can only hear a patient. And that's very, very important. As I alluded to, there are many visual cues that are important to see: fear and expressions and the tone of a voice. Many things you can pick up. And I would say the relevance to this discussion in today's COVID crisis is, for me, and it's highlighted again, is beyond the pathophysiology that I'm looking for, as understanding whether someone's symptoms that are concerning warrant a higher level of care. It's how do I give a a therapeutic dose of compassion to my patients in a time when their stress is off the charts. And the opportunity here to use this technology where people are shuttered in their homes, can't move around, is to help de-escalate stress, provide a human element to this story that's so important in understanding where people are as human beings, while we're also understanding where they are from a potential illness standpoint and need a higher level of care. So these are fundamental issues of what it is to be a family physician, quickly establishing a relationship and helping people where they are emotionally, as well as gaining information. And I'll just say one last thing that helped me many years ago, about a decade ago, where I helped a nurse practitioner over a long distance call. She was in a community many kilometers away from where I was. And I saw a complex patient with her, and spent 45 minutes trying to sort things out. And I'd never seen this patient, never met them physically. They had never met me. And at the end of that visit, that patient said unequivocally that this was the best doctor-patient visit they had ever had in their life. So, it's a one-off, I get that. But it taught me that we can establish solid relationships and trust in the moment with patients that we never met before. And that's the opportunity, that's our job. And we have to think about that, about how we're going to do that properly.
And I wonder, John, if it would be useful at the beginning for a doc and or a patient new to this, just to acknowledge that this is a bit different, but let's work together, and I'm going to do my best to figure out how to help you best, and just kind of naming the awkwardness for those folks who are just warming up to the medium.
That's a very good point, and I think it's important for both the provider and the patient to perhaps acknowledge that. And for many health providers that have found themselves swimming in this water now, as you say, Jeff, they had to move past the toe dipping stage to somebody pushed them off the end of the dock, and now they're in there. And a lot of people feel that they're over their heads. Yep. But being truthful to your patients, we're in this together, and we are in this together, metaphorically and literally. And so I think, again, that humanizing the experience helps everybody move forward in a much safer way.
Over to you, Mark. We've got several questions on Facebook regarding prescribing, and just kind of where's the line of safety in terms of being clinically effective and protecting medical legal risk in terms of prescribing based on video visit, presumably sometimes without lab or X-ray. Just any approach to what's been your approach around the comfort with that? Again, recognizing you're both more seasoned in this kind of work than maybe some of the folks listening are.
Well, I think to again elaborate on what John has said, if we believe that we're doing an adequate assessment, then our treatment decisions in virtual care are not changed. A plan of treatment, which may include a prescription, an investigation, a referral to a specialist, it may include time off work. If we are satisfied that we've met that standard, we'll be fine. However, from the perspective of have we acted responsibly as doctors, that's not going to be a problem. However, and it is important to note that most Canadian jurisdictions, like a Dialogue where I've done the majority of my telemedicine work, we work in all 13 Canadian jurisdictions, all 10 provinces and all 3 territories. And many jurisdictions have college regulatory policies, the ones who issue our licenses or permits to practice, that expressly prohibit certain drugs. For example, Quebec does not permit the prescription of opioids, cannabis, benzodiazepines, or stimulants via telemedicine. Point final, as they say en français. There's no discussion. Most provinces also have provisions for in cannabis policies, some of them in opioid policies. It can vary where you'll find them on your own regulatory college's website. but you should not be prescribing what is expressly prohibited in usual situations. What kind of allowances will be given for the current crisis, I don't know, but I personally still don't prescribe from the Quebec list. I think it's reasonable, and it's not something that I would want to engage in.
Mm. John, do you want to comment on that at all? You've treated sepsis by virtual health, so that I guess implies there's someone at the other end helping, I suppose. But
yeah, so I take a different approach in BC. Virtual care doesn't change the rules of what I do. It extends the opportunity. So again, in my family practice, which is founded on trust, relationships, and longitudinal care, I provide the same level of care whether I'm virtual or not, understanding that I have to do things a little bit differently. So for example, I work with nurses to start Suboxone when it's appropriate. I write restricted medications with a duplicate prescription so that a patient can start on these medications if need be. If a palliative patient needs a narcotic for pain, I will make that happen. If there's a mental health crisis, I will do what I have to do. So I see myself as the provider who provides care in a safe, effective way, irrespective of whether I'm there physically or virtually. I just have to understand how to safely do that. So I think the question highlights where the vulnerability is, the thin ice, in other words. When family physicians are working with patients, they know they have a longitudinal medical record, they have an established relationship. You can do these things. You do these things very safely, and in fact, it's safer than oftentimes much safer than if I didn't do that and I forced the patient to travel down a dangerous road and get killed. Okay, so again, people need to think about holistic risk, and a lot of times these rules and regulations are made by regulatory bodies that perhaps haven't thought through the holistic risk of what it is to do or not do something. And that's our job as family physicians, is to understand what is the holistic risk involved here. It's easy to just say, no, I won't do that, but that doesn't necessarily help your patient. I think in the era of COVID, all bets are off. You have to, this highlights the need to bring public safety right to the fore here. What in this moment in time is the safest thing for my patient to do? There's no question that this highlights it in a dramatic way for everyone. So whether you agree or disagree with whatever rules out there, you're making a decision that a patient's life could hinge on that. And so for me, that brings clarity to this issue in a way that we haven't seen before. Mm-hmm. And so writing a prescription, we see this a lot. Addictions has now has been amplified as an issue in terms of access to addictions care in the time of COVID, because for vulnerable populations and rural, remote, indigenous communities, all the gaps in the healthcare system are amplified and illuminated in dramatic ways. And so how do these people get care that they need? And when clinics are closing and access to pharmacies is less, and so on and so forth. So we have to reach out as best we can in a safe, thoughtful way to provide people with care in new and novel ways. And we're doing this on the fly, but we're doing it in thoughtful ways that are not reckless, but they're considering the whole picture of the patient. And I think my last thought on this particular topic, which obviously I have some personal views on, is that we will probably see things change around what this looks like post-COVID, because we're emphasizing patient safety and what in fact is in the best interest of the patient. So hope that's helpful.
Great. It's interesting thinking about the things that are going to be changed forever based on these rapid shifts in practice. Mark, we've had a couple of questions about out-of-province patients. Ontario docs with patients sitting in Florida, not coming home for the moment. People out of province for those in border communities. I know that this varies a bit province to province, but I Wonder what advice you have for family docs around being approached by patients out of province, out of country, looking for medical support, help by phone, by video with us.
Yeah. Most of the industrialized world follows the principle that the physician must hold a permit to practice where the patient is located at the time you're connected. Where the doctor is located is immaterial. So if a physician wants to spend a month in Florida or a month in Palm Springs and see patients back home, that's not going to be a problem from the perspective of holding a medical license. The problem arises going across provincial borders. 4 Canadian jurisdictions will accept a doctor assessing a patient who is in their territory, as long as they're licensed in Canada: BC, Ontario, Nova Scotia, Newfoundland, Labrador. But the rest of them expect the physician to be licensed locally. Most people think that this is outdated, and there is a move afoot to try to fix that. So within Canada, those are the rules. I don't know of any case of a physician being charged for practicing medicine without a license. There are some regulators who are particularly stern in their language. That would have to be for each physician to inform themselves. Going out of country is a completely different story. So going into the US, again, there are 50 licenses to practice, one for each state, plus probably territory, Puerto Rico, Guam, whatever. If you don't hold a license, you are practicing medicine without a license. And in the US, practicing medicine without a license in some jurisdictions is not only against the law, it's a criminal offense. So that's pretty daunting to begin with. But perhaps more worrisome, our insurance with the CMPA does not cover us providing services to patients who are outside the country, unless it's like an immediate follow-up of something you've already assessed. So if a patient comes in, has abdominal pain, you order an ultrasound, they get it the next week and leave the following day to Florida, there's an important finding on the ultrasound. It's no problem to communicate with the patient to follow on the episode of care that's been initiated. But if the patient has a new problem and calls you from the US, the CMPA is very clear about this. They will probably not protect you if the patient pursues that, and particularly if the patient pursues it in a US court or wherever they are in a foreign jurisdiction. Again, for each physician to make their own decision, but contrary to what patients and doctors might think, our malpractice insurance is based on the principle that the patient is in Canada when the service is being provided.
Thanks for that. Another question, John, I'll turn to you for this one for first response. And it's kind of about outreach to patients and equipping patients to play their part. One of the questions is about how we ensure that patient on the other end of the call or video visit has the right setup. What do we need to instruct them around the kinds of technologies or other considerations? And the related question is, given the fact that many family docs in clinics are depending on virtual visits more for to keep the ship afloat, how do we get the word out to patients that this service is available and we're able to help them in this way? So 2 questions, I guess, there. But the first around how do we, what do patients need to be told to make sure they have to do this effectively, especially by video?
Sure, great question. So with respect to the messaging to the patients, I think, again, COVID highlights things in dramatic fashion. So clinics are the door is locked, and there's usually a message on the door saying we've transitioned over to a different way of accessing care, and here are the steps to do it. People just can't walk into a health center like they did 2 months ago. So that just is what it is, and it's the same wherever you go. So very quickly, people have realized that you can't just walk in the door and sit in a waiting room. That's not happening today. So in terms of how do we help patients, I think that many doctors are scrambling to get information from their respective professional bodies. I know in British Columbia, the doctors of BC is doing an amazing job disseminating very helpful information to meet those needs, both for patients and providers, trying to help providers help their patients, in other words. And that's, again, people are learning, people are drinking from a fire hose on this one for sure, and taking in a lot of information where, they might be starting really cold on with virtual health, but the need to do this, of course, is a life-saving maneuver, so everyone is doing it. In terms of understanding, this is, the technology that's needed. The right technology is the technology that works for your patient in that moment of time. So I use a variety of technological tools, including the telephone, including texting and messaging, and I use Messenger and WhatsApp. I use a really expensive fancy video conferencing equipment. I use the tool that helps my patient where they are at that particular time, understanding that all the tools have vulnerability, and you need to understand which ones are better than other ones. But by not connecting, by saying I don't have the right tool, therefore I won't connect, does your patient potential harm. And the harm today is that patient may move around in society and potentially spread a virus, contract a virus, which can lead to death. So we've seen in British Columbia is that in terms of the usage of certain kinds of technology, it's basically now use what you need to use to safely connect with your patients. That's it. So whether we use FaceTime, whatever. And I think by doing that, by meeting your patient, what do they have? What do they have available to them? And that's the premise I work from. And then I try to connect with them by what they have rather than trying to force them down a pathway that they don't understand, that's unfamiliar to them, and that is clunky. And so, again, this is a healthy dose of common sense needs to be utilized during this public health crisis.
Thanks. Just and over to Mark on that point. I guess around privacy, are there security risks with some platforms? Like in Manitoba here, I know there's been the approach John just described of telling doctors use what you can, use what patients have. We want to move you onto more secure platforms, but do what you need to right now. Is online security privacy? Talk a bit about that, and I guess also about the notion of privacy during the visit, and to what extent do we need to talk about privacy with the patient in the visit to reassure them that we're alone or to make sure that they're not in a public place. So there's kind of the technical aspects of privacy and security and also the interpersonal ones. Maybe, Mark, if you could talk a bit about each of those.
So the first one, the technical aspects, what John just enumerated, I don't have an issue with any of it. I mean, there's an abundance of platforms out there, both specific for medical care and more general ones that are as secure as you can get. They encrypt the signals from end to end, and someone trying to listen in would have to be extremely sophisticated to be able to do that. But extreme sophistication would allow you to plant a microphone inside a doctor's examination room. So I think that when it comes to the tool, it's pretty good. For example, I think several of the provinces have already named Zoom and Skype as potential tools to use in addition to dedicated health ones. Some people would say FaceTime, that's an Apple proprietary product, so you need someone who's on Apple to do that. You're also going to need an ID that distinguishes your personal from your professional life, or at least most people, I think, would prefer to do that. But I don't think that the technology is really an issue, any more than it would be in any other kind of encounter. When it comes to the mechanics of, the patient and the doctor not being in the same room and having the visible cues that help confirm that the doctor is alone, simply telling the patient, look, I'm in an enclosed room, the door is closed. It's as private as my exam rooms are because that's where we should be working, whether it's a home office or your regular office. And just checking with the patient to ask if they have sufficient privacy around them to speak openly. Many patients can solve it by just putting in earphones, because once the earphones are in, whoever's around them can't hear what we're saying. And if they give us a signal that we've got to go to kind of yes, no answer approaches to discussing with them to maintain their privacy. What I would say for physicians who are concerned, about the patient's environment, I never enter into a video encounter with a patient without assuming that there are other people off camera in the room, and I think you should be having the discussions just like you should write a chart note, as if the patient themselves or anyone might eventually read it who has right of access to that patient's health information. You should simply have the discussion with the same principle in mind.
And I note that, the general standard is that the kind of clinic encounter note we need to make is the same as for any other visit, and that documentation is important. And I'm sure for many of us, it may feel a bit more important as we get comfortable ourselves. John, I have a question about teaching. You're very involved at UBC, and I have a couple questions about supervising trainees, medical students, residents on virtual visits. You may be in the same clinic or hospital as them, or you may be in a different one. For those of us who are medical teachers, any particular tips and tricks that you have learned around involving trainees in this kind of care?
Yeah, it's a great question. I think we've entered into an era now where e-health, if you will, is being integrated into the curriculum, both in the undergrad and postgrad realm across medical schools in Canada. So students coming out with some core competencies, if you will, around e-health, virtual visits, and so forth, is becoming more of the norm. Family practice residents are, again, this is becoming, this whole COVID era is going to catapult not only working clinicians, but academia into a new space with respect to virtual health. So where I used to struggle with my peers at the university as to the importance of trying to integrate this into the curriculum, I feel pretty confident that I'm not going to have to twist any more arms to do so, because this public crisis has illuminated why we need to do this. The tricks beyond the etiquette are professional behavior, how to comport oneself, understanding what the limitations of a virtual visit. These are all the kinds of things that one has to review with learners. And then there's the in this era, the mantra in health, as physicians, see one, do, and teach one. That's what we kind of live that mantra. But again, in a healthcare crisis, that's essentially what you literally have to live. So I have family practice residents who come and spend time with me. In my telehealth office, they understand how I see patients. What is the workflow? How do you document? How do you do prescriptions? How do you do prescriptions of restricted drugs? How do you order investigations? How do you connect with a specialist colleague? How do you do all those things? And I've had many residents who are now practicing clinicians who are now texting me back how grateful they are to have had that experience, because it's helping them a lot right now, adopting technology into this current time to help their patients. So we're going to need to formalize these learning opportunities and teaching pathways for family practice residents and medical students. But it's all coming, and I believe in the months ahead, the next iteration of curriculum development will see a massive growth in how we embed e-health into the core curriculum. So I hope that's helpful.
Thanks, John. That will apply to both medical education and education in general, as schools are facing similar challenges, of course. Mark, a question to you about some of the practicalities around doing this work. Two things. I'll start with screen management. I'm struggling with that right now. Many of us are, as we do more virtual care. And I'm just wondering if you can comment on the ways that you set up visits in terms of hopefully wanting to have access to the electronic chart, if you've got one, as well as to the video screen and other screens. So just how do you set up your workplace to have the information you need available?
So long before virtual care became an option, I was a big believer in the published research on ergonomics that shows that most people use screens that are way too small. And unfortunately, before that research took hold, laptops took over from desktops. And I'm always amazed at how many of my colleagues are willing to consider a usable tool, a laptop with a 14-inch screen, which I find astounding. I've worked with at least a 24-inch screen on my desk for 15 years, and I currently use two 27-inch monitors. I think it's important when you're coming into virtual care to recognize that whatever screen space you need for a window, let's say for a medical record, and if you have another window for a provincial viewer open at the same time, and perhaps another one that's an internet one, whether you use UpToDate or you want to look something else up, that the window that you need to look at the patient is yet more screen real estate. And if you weren't committed to getting a larger screen or adding a second screen before you started virtual care, you really should look at that. I think that's really important to set up the kind of space so that you can use it. Good high resolution camera. While high resolution can make the video choppy if you don't have great bandwidth between you and the patient, it does make your image that much more present to the patient, and it does help with making the connection, I've found. So I think that that's part of kind of the technology setup as well. And, for the electronic records, I think that my hope is that most people have an electronic record, and if they do, they have some means of remote access. If you do and are already doing that, then that part's taken care of. If you don't, I could only encourage you, before you try setting up a second medical record system, whether you use word processing files or whatever, I would first strongly urge you to try to connect to what's your regular record, which will be more secured. If you're going to go to records that you're maintaining as documents on your own computer, please make sure that the disk they're stored on is fully encrypted. You could use an external encrypted USB drive if you're not sure that the primary drive on your computer does that. Because if a computer were to get stolen or some kind of mishap arises with unencrypted data on a drive, that's a way to get yourself in the newspaper for more than a day even.
John, I'm going to put this next practical question to you, and it's around forms, managing the receipt, completion, submission of the many, many forms that we have to do for patients. How do you manage forms in the virtual care that you do?
Okay, I'm going to ask that, Jeff, but I'm going to go off script and go back to Mark, if that's okay, because I just want to get a couple more practical points, if that's okay.
Please.
As someone who does a lot of this, and people are going to be doing this a lot, workplace injuries from telehealth, self-confessed, I got a frozen shoulder. I switched over to virtual care, and I was sitting in front of a computer all day, hunched over and doing my work. Very quickly, over a number of months, developed a bad shoulder. I have a stand-up desk now. I encourage people to get a stand-up desk. Don't sit at a chair all day. When you're doing this from sun up to sundown right now, it's great to be on your feet and move around. So think about ergonomics. Think about how to stay physically well as mentally well while you're doing this. Eye strain, other things like that. People can get headaches, and just some practical advice, as well as what your posture and your hands. Again, we get overuse injuries from that we see in clinical practice from people who present who are doing this all day long. So here we are now. Our workplace has changed, and we have to think about those things critically. But the stand-up desk has been transformative for me. So that's practical advice number one. The second bit of practical advice, not to discount anything Mark said, because it's all 100% correct, but I'm a big believer of simplicity. So the smartphone can do a tremendous amount of good in all the space of virtual care, but especially in a healthcare crisis. So the smartphone's kind of the Swiss Army knife of virtual tools, if you will. And other than it's hard to document on there, but even that's starting to change, where there are dictation systems that are secure that are coming out that will be able to mesh with your EMR and all kind of stuff. But for people that are starting, my strong suggestion is, again, keep it simple but safe, and absolutely you need multiple bits of technology to do this well. Something to document. You need to be able to look up on databases and electronic health records from hospitals. In British Columbia, we have a PharmaNet program to look up prescriptions, see what people to make sure that you're safely prescribing this kind of thing. So you need to have access to all those things, and you're toggling between windows all the time. So it doesn't take much to get going on this. You get better at it as you go, but the simpler you start, the less anxiety you will feel in going forward, connecting with your patients after you do a few of these things and you see it's not so hard and you document it. And again, coming now to your form question. So we filled through the EMR, we do forms. We have a form pathway in our EMR which has all the usual forms that you would 20 years ago I used to have in these little plastic folders on the wall kind of thing. So now I just tick, they auto-populate with the patient's contact information and so forth. In British Columbia, depending on what it is, I can attach an e-signature, ask my MOA to fax it to a lab or to a hospital or wherever it needs to go. Doctor's notes, what have you. I do work safe things over this way. And so forms can be done effectively that way. And again, in the time of COVID, some of the rules and regulations around some of these restrictions on, thou shall have a wet signature on this kind of stuff, trying to force people to go in. Of course, that behavior is being strongly discouraged, so that more and more can happen virtually. So I hope that helps with the form bit.
It's a great answer. Over to Mark with this one around, whether the telephone is sufficient. A couple people commenting on, am I okay to stick with the phone, or is there a strong case to be made for getting into the video visit modality as well? And I guess the general question would be, what extra information do we get by video that makes that something we should consider or not, from your point of view, Mark?
It's a great question, and I think John and I, are each in our own ways, have alluded along, throughout this webinar, that medicine is medicine, and we're pretty good at judging what's safe. Long before COVID came along, and even before video conferencing came along, I was doing up to 10% of my encounters with patients over the phone. So the phone's a really good tool, and there's a lot that we can do. But what we can't do over the phone is visually inspect. Now, I didn't have the opportunity to very strongly endorse what John had mentioned earlier, which is, of course, that it's very different working with a patient who you're seeing as a one-of encounter and someone with whom you have a continuing relationship. I think all of us know that people who we've known for several years or even several decades, we can tell by their voice on the phone a lot more than a doctor who's never met them before. So I think that the answer has to be individualized to the circumstances, but the one general statement I can make is you will be able to do more via video connection than you can do on pure voice. And so if in this age where we're trying to be able to provide every possible substitution of service via virtual versus conventional in person, I would encourage people to try to find ways to be able to introduce this into their day-to-day.
Thanks, Mark. And John?
Well, just to help the audience, again, referring back to that paper that we put out in 2016, the Canadian Family Physician, speaks to exactly your point, Jeff, around the difference between a telephone and a video call and the value added part of a video call. And again, the verbal and the nonverbal cues, understanding what those differences are, and that highlights and answers your questions specifically. So I encourage people to look up that paper. You just Google my name or Dr. Stefan Grabowski, Canadian Family Physician 2016, and it will highlight some of the elements that we've spoken here today.
Well, thanks to both of you. Thanks to Mark, thanks to John for being available on quite short notice to help make this happen today. I do want to direct everyone to the cfbc.ca website. We've got a banner with COVID-related resources. And I think we'll make sure, John, that article you're mentioning is up there, as well as some virtual care resources that have been alluded to. In my perusing of resources the last few days, there is great stuff in Ontario from the Ontario Telehealth Medicine Network, from Ontario MD, Doctors BC, and many others. There's a lot of folks trying to jump to the pump, and we're all getting access to that, but we'll make sure it's available for you on the cfbc.ca website. Information about further clinical webinars will be there as well. We're going to definitely be doing this in 2 weeks. We're hoping to get one up next week if we can get our speakers organized. And again, that'll be likely at 12 noon. Maybe Thursday, but we're going to see how the schedule evolves, but look forward to more information about that. And a shout out to Brian Cote, our video master, who's sitting at home making this happen for us and not in the CFPC studio, which we usually use. So thanks to Brian and the whole practice support team led by Mike Allen for helping us be in front of you today. Again, thanks to Mark and John, and thanks to all of you for taking an hour out of your day. Reminder that MainPro Plus certified credits are available. Look for the link in the chats. Go there and complete that short survey between now and tomorrow. And again, let everyone know that this is available in archive format as well on the CFPC website on our clinical webinars webpage. So with that, thanks for tuning in this afternoon or this morning, wherever you are. Thanks again to Mark and to John, and best of luck to everyone as we face the challenges this week is bringing. See you next time. Okay, well, thanks very much, guys. That was